Good morning, everyone. Thank you, organizer, for this opportunity. So before discussing today's paper, we'll have a sneak peek on Pacific trial where Durvalumab was compared with placebo post-concurrent chemoradiation in stage 3 patients. So if you see the key secondary endpoints, patient-related outcome on toxicity was one of the key secondary endpoints. And this paper presented in ELCC this year exactly discuss about it with where author discuss about impact of grade 2 or higher pneumonitis on patient-reported outcomes with Durvalumab after chemoradiotherapy, that's Pacific trial, in unresectable stage 3 NSCLC. So we know concurrent chemoradiation is the standard treatment modality in stage 3 unresectable lung cancer, but with median overall survival of 18 to 30 months and 5-year survival of 20 to 30%, there is a huge unmet need in terms of survival. And also, radiation pneumonitis is the dose-limiting toxicity in patients undergoing chemoradiation. Most of the study and most of the clinicians usually follow V20, that is volume of lung getting 20 gray or more, less than 35% as a cutoff for concurrent chemoradiations. So objective of this paper was to assess the effect of grade 2 or higher pneumonitis on patient-related outcome with Durvalumab in Pacific trial. And aim was to investigate whether the occurrence of grade 2 or higher pneumonitis during the study actually impacted the tolerability of Durvalumab from the patient's perspective. So there are many inclusion and exclusion criteria, but I will be focusing more on those pertaining to pneumonitis. So they actually, in Pacific trial, they actually included only those patients who had mean lung dose of less than 20 gray and V20 of less than 35%. So those patients which have having a more than 20% chance of having pneumonitis were initially excluded, and patients who had grade 2 or higher pneumonitis from previous chemoradiotherapy were excluded from the study. So actually, those patients having high risk of pneumonitis were actually excluded initially. So pneumonitis was investigated, assessed, and defined as focal or diffuse inflammation of lung parenchyma, acute interstitial pneumonitis, interstitial lung disease, pulmonary fibrosis, alveolitis, diffuse alveolar damage, and radiation pneumonitis were all included as pneumonitis. Any test, any serologic, immunologic, and histologic testing recommended to rule out other causes of pneumonitis were allowed. And patient-related outcome were assessed by paper-based questionnaire, that is URTC quality of life 30 and URTC quality lung cancer 13. And it was administered at the time of baseline, that is study these are week 4, week 8, then every 8 weeks until week 48, and then every 12 weeks until progression. So this is exploratory post-hoc analysis and based on intention to treat population. And changes in PRO score from baseline were summarized according to the presence or absence of grade 2 or higher pneumonitis. And clinical meaningful difference was defined as more than 10% point increase, that is worsening of symptom, or decrease, that is improvement of system. So changes in scores were assessed at week 16 and 24 to reflect the typical time frame of pneumonitis. 2 sets of covariates were used to account the possible correlation of grade 2 or higher pneumonitis with baseline factor. Model 1, which include base model and include age, sex, and smoking history, and model 2, that's base model plus additional baseline prognostic factors. So if you see the results, how common was pneumonitis? Most patients in Pacific trial had at least one adverse event, that's 96.8% in Durvalumab and 94.9% placebo arm. Any grade pneumonitis was the most common as expected, occurring in 1/3 of patients in Durvalumab arm and 1/4 of patients in placebo arm. Grade 2 of high pneumonitis occurred in 19.7% of patients assigned to Durvalumab and 13.9% in placebo arm. So the most frequent adverse effect that lead to discontinuation of Durvalumab and placebo was pneumonitis. That is 6.3% in Durvalumab arm and 4.3% in placebo arm. So how severe were the pneumonitis? Grade 1 was 14.2% in Durvalumab and 10.9% in placebo arm, and grade 2 was 16.3% and 10.9% in Durvalumab versus placebo. And we can see grade 1 and grade 2 are obviously higher in Durvalumab arm. But interesting was that grade 3 and grade 4, there was not much difference, 3.4% in Durvalumab and 3% in placebo arm. So how this pneumonitis actually impacted the patient's outcomes? Actually, as we can see from previous slide, pneumonitis predominantly occurred in low-grade severity, and treatment benefit with Durvalumab was maintained regardless of the occurrence of pneumonitis. No clinically meaningful changes in score for patient-reported outcomes were observed at week 16 and 24 among patients assigned to have either of the treatment, whether they experienced grade 2 or high pneumonitis. Up to 12 months of Durvalumab therapy administered following chemoradiotherapy did not have a detrimental impact on patient quality of life compared with placebo, whether patient had grade 2 or high pneumonitis or not. In this bar diagram, we can see in patient, whether they have grade 2 pneumonitis, absent or present, almost, this is a bar diagram showing compliance with URTC quality of life 30 and LC 13. So almost 70% of patient actually has compliance to the treatment. But when you compare having patient with grade 2 pneumonitis or without grade 2 without pneumonitis, we can see the patient with the grade 2 pneumonitis have lower compliance compared to who do not have pneumonitis. So this is another bar diagram which shows changes in score for pre-specified PRO at week 16 and 24. So here we can see if there was grade 2 pneumonitis present, symptoms like cough, dyspnea were worsened, and there was improvement in other symptoms. However, if there was no pneumonitis, all the symptoms were improved. However, none of this reached clinical significance, that is 10-point difference from the baseline. And in this forest plot, which shows the confirmed time to deterioration for patient-related outcome of interest, adjusting for time-dependent grade 2 or higher pneumonitis, we can see time to deterioration was not much difference in physical functioning and cough in both the arms. However, time to deterioration was prolonged in global health status, chest pain and hemoptysis in Durvalumab arm. So to conclude, pneumonitis is dose-limiting toxicity in concurrent chemoradiation, and when we add Durvalumab to it obviously adds toxicity, but in carefully selected patients, that is patient without grade 2 or high pneumonitis post-chemoradiation, Durvalumab can be safely administered without compromising survival outcomes and quality of life. Thank you.